So, hello, Katsu. It's very nice to see you here today. I'm looking very much forward to interviewing on your interesting results from the CSPS-COM trial.
Thank you.
First, I would like you to give us the basic facts on the CPS-COM trial, just for those who do not recall it.
Okay. Thank you, Hanne, for your next question. So, CSPS is the name of Cilostazol stroke prevention study. CSPS is a series of RCTs to ascertain the impact of Cilostazol on secondary prevention of non-cardioembolic stroke. So, Cilostazol is a phosphodiesterase 3 inhibitor that developed in Japan in the late 20th century. It is an antiplatelet agent, and in addition, it has pleiotropic effects such as vasodilation, vasoprotection, neuroprotection, and others. Such pleiotropic effects cause low risk of bleeding. So, in the series of CSPS, in the first CSPS trial, Cilostazol decreased recurrent ischemic stroke with a similar risk of serious bleeding compared to placebo. In CSPS2, Cilostazol decreased recurrent stroke with half the risk of serious bleeding compared to aspirin. Now, in the third CSPS trial named the CSPS.com, Cilostazol plus aspirin or Cilostazol plus clopidogrel had a lower risk of ischemic stroke recurrence and a similar risk of major bleeding compared to aspirin or clopidogrel alone in patients with high-risk stroke recurrence. Now, dual antiplatelet therapy was thought to be effective only for acute to subacute stroke. However, if we choose Cilostazol, we can effectively and safely use dual therapy or chronic stroke, I think.
Thank you very much for this update. Now we all know what we're talking about. I would then like to describe what is really the topic of this, the secondary analysis that you're presenting at the Esoc.
Yeah. Okay. So in this secondary analysis, we looked at timing of treatment initiation. As I said, aspirin plus clopidogrel is effective and safe within the initial few weeks after stroke onset. So if we can prove that dual therapy, including Cilostazol, is effective in both subacute and chronic stage of stroke, we can perform seamless dual therapy from acute to chronic stroke by switching from aspirin plus clopidogrel to Cilostazol plus other one at some optimal time point. So, in the CSPS.com, patients between 8 and 180 days after stroke onset were eligible. Thus, we divided the patient into 3 groups by the time of initiation of the trial medication. The first group between 8 and 14 days, the second between 15 and 28 days, and the third between 29 and 180 days after stroke onset. In the first timing group, the recurrence of ischemic stroke was similarly common between dual therapy, including Cilostazol, and monotherapy. In the second and third timing group, the recurrence was less common with dual therapy than monotherapy. And severe bleeding occurred similarly between patients on dual therapy and those on monotherapy in any of these 3 groups. So now we notice that long-term DAPT using Cilostazol is more effective for secondary stroke prevention than monotherapy when it is started at 15 days or later after stroke onset. Then we can perform seamless DAPT strategy by switching the regimen at the 3rd or 4th week after onset from aspirin clopidogrel to Cilostazol and something. Yeah, that's a new concept of this study.
Okay. but in trials with other dual antiplatelets and early initiation of treatment, most benefit has been observed early. What are your thoughts on this difference?
Yeah, thank you for your question. This is the most interesting point of the study, I think. So in the main analysis of the CSPS.com, the event curves of ischemic stroke during dual therapy and dual monotherapy separated gradually from 3 to 4 months after randomization. A similar separation of the event curves at the chronic stage was observed in CSPS2 and catalysis trials that compared cilostazol monotherapy or cilostazol plus aspirin with aspirin monotherapy. So this delayed preventive effect against stroke suggests the contribution of the long-lasting pleiotropic mechanisms unique to cilostazol. To prevent thromboembolic events soon after stroke onset, strong antiplatelet power is needed. But cilostazol may be somewhat weak regarding antiplatelet power. Instead, vasoprotective and neuroprotective effects unique to cilostazol seem to be effective for stroke prevention when the drug is used for a long time in the chronic stage, I think.
I think that is a very, very good response. So I was thinking, everybody wants to know what to do when they get home from a convention and have learned a lot of new things. So I would like you to tell, how do you personally translate these results into your own clinical practice?
Yes. Cilostazol plus aspirin or cilostazol plus clopidogrel is the only established dual therapy for chronic stroke after this CSPS.com. So you can choose this new depth regimen for your chronic stroke patients. You can change from aspirin plus clopidogrel to this new combination around 3 or 4th week after onset. The problem is all the CSPS trials were performed in Japan. And there are also several excellent papers on cilostazol for stroke from Korea, South Korea. And now many Asian stroke patients are using cilostazol. But one of my interests is if DAPT using cilostazol is also effective in Western countries, in Europe or in US. The good news is my European and American friends are now planning a similar clinical trial using cilostazol. So I really hope that cilostazol contributed to stroke prevention for global patients without racial differences in the efficacy.
Thank you, Kazu. It's been really interesting. Thank you so much for sharing your knowledge and insights and thoughts on this drug, which we're not used to using in many Western countries. Thank you very much.
Yeah, thank you very much, Hanne. And thank you very much, everybody.